Good afternoon, everybody. It's a pleasure to be here this afternoon, moderating with Dr. Drew Singal and Dr. Jeff Weinstein here. My name is Leo Tai, I'm one of the radiologists here at the Beth Israel Deaconess Medical Center. And we've entered the lymphatic imaging portion of the program. And with us today are three very distinguished speakers to speak on topics related to MRL, nuclear lymphoscintigraphy, and then let's see, sorry, excuse me. So the first speaker I wanted to introduce was Dr. Max Itkin. He is a professor of radiology and pediatrics at the University of Pennsylvania, where he's also the co-director of the Center of Lymphatic Imaging and Interventions. Dr. Itkin is a nationally and internationally recognized individual for his research and his clinical expertise in imaging of lymphatics. He's very well known in our specialty of radiology in this field, and we're thrilled to have him speak on this topic of MRI and MRL. So, Dr. Itkin.
Thank you very much for inviting me to speak today about MRL lymphangiography. The staple of the lymphatic imaging for many years were beta lymphangiography on the left and lymphoscintigraphy on the right. Both of them have significant drawbacks. Over the last 10 years, the new technique was developed, intranodal interstitial lymphangiography. During this technique, we inject lymph nodes with contrast, and thus we can ossify the lymphatic system. There's a few places where we can inject contrast. We can inject it most common inguinal lymph nodes because they are the most accessible, mesenteric lymph nodes, but also we can inject in the liver lymphatics in the periportal space. There's other places such as axillary lymph nodes and neck lymph nodes we can use as well. This is how it looks. Ultrasound, we see beautiful lymph node and advanced needle into it. On the right, you can see the patient with 2 needles into the groin lymph nodes. And on the left, there's an ultrasound image of needle piercing the lymph node. And we usually position the needle in the middle of the lymph node or sometimes in the outflow. Originally, we developed, and others developed this technique using for injection of lapiodol for imaging, interprocedural imaging. However, a few years later, we decided to start injecting gadolinium contrast in MRI. There are a few logistical and technical challenges. One of them is that it's not very common to put ultrasound machine in the MR magnet. For that reason, you have to do placement of the needle outside. And of course, when we move patient from one table to another, the needle can dislodge quite easily. Fortunately for us, the new generation of MR scanners comes with detachable table. And we can take this table, position outside the MRI, put needles in the groins, and inject contrast. How do we know that we are perfectly positioned in the lymph node and the ossify efferent lymphatics? We developed this technique of injection of ultrasound contrast into lymph node, and on the right you can see the image. However, in some countries, Europe or South America, they can place their ultrasound machine inside the MRI according to their regulation. So it obviously makes things much, much easier. We usually inject gadolinium contrast using injector, and this is our makeshift setup for this injection. The importance of that is that first you get very consistent injection, number one. Number two, you can actually calculate the flow in the thoracic duct while you know what is the injection rate in the lymph nodes. These are the MR sequences what we use. T2 sequence, primarily to see the lymphatic masses, effusion, edema in the tissues. Then we do fast angio acquisition technique. In our case, it's Siemens twist. In this way, we can dynamically evaluate the lymphatic flow. It's particularly important when we're talking not just about anatomy, but also about the physiology. And then we'll do delay high-resolution angio images. That allow us to continue to image. For example, if during the first 10 minutes of fast acquisition, we didn't get good imaging. Also, it provides the high-resolution visualization of the lymphatic system. Of course, first part done with no contrast, and the second two with contrast. Here's an example of the retroperitoneal masses, pleural effusion, pericardial effusion. And that's quite important for us to see, because sometimes the pathway of the contrast does not go through these lymphatic masses. This is another example of the T2 imaging that, of course, images water of the mediastinal masses. And this is an image of the dilated tortuous thoracic duct in patient with heart failure. You can also observe in certain disorders, such as GLA, KLA, masses in the bones or spleen or liver. So what are the advantages of the gadolinium contrast versus conventional lymphangiography, what we use lapidal or contrast? Number one, gadolinium is less viscous. It goes where lapidal does not go, penetrates much deeper. MRI obviously has very good contrast resolution and 3D imaging ability. And of course, as I said, we can collect the dynamic data. This is an example of the MR lymphangiography of the thoracic duct. That's relatively normal thoracic duct. A little bit tortuous, a little bit dilated, but flow goes quite well. We started to experiment with measurement of the lymphatic flow based on MRI. And this is our first attempt published in Radiology, where we first extracted the contrast data and then plotted it against time. And we can see that we can differentiate the different flow between different groups of patients. We deliberately picked up the very different groups, heart failure, normal, and neonates. And clearly we can see the difference. It's a work in progress. So when do we use MRL? First, to demonstrate lymphatic anatomy, presence of the thoracic duct, number of the ducts, identify the pulmonary lymphatic abnormality, chylothorax, plastic bronchitis, and more. Usually we see this abnormal lymphatic flow from the thoracic duct in the lung parenchyma. And also we routinely do MRI for chylosositis, chyluria, lymphoria, genital or peritoneal, because it gives us information about the pathological abnormal lymphatic reflux. But in some condition, the abnormality is invisible. Comparing to the vascular system, where we can inject contrast in the root of the aorta and you can ossify all vessels in the body, lymphatic system is built from multiple subsystems. So you could never actually image the whole lymphatic system. You're always limited to some parts. And most common injection, as I said, is an intranodal inguinal lymph nodes. The contrast propagates from the inguinal lymph nodes through the retroperitoneal lymphatic cisterna cali in the thoracic duct. And on the right, you can see the pathway of the chyle that comes from intestine. And as you can see, the part of this chyle pathway that is mesenterium is outside the pathway of the contrast injected in the lymph nodes. So in these cases, of course, we have to do mesenteric lymphangiography. And this is example of the abnormal lymphatic flow from the thoracic duct into the lung parenchyma in this patient with idiopathic chylothorax. And on the right, you can see that there's a corresponding imaging of the injection of the contrast inside thoracic duct. This is an example of congenital lymphatic dysplasia, non-immune hydrops, that this picture can explain you what's going on. And what's going on is total absence of the thoracic duct. But contrast MRL has some pitfalls. And one of the important pitfalls is that the contrast sometimes does not go in the area with high pressure. We see it in neonates quite often, and in some adults. Here an example of the MR lymphangiography in kids with neonatal hydrops. You can see the reflux of the contrast into subcutaneous lymphatics and no opacification of the thoracic duct. Does that mean the thoracic duct is absent? Absolutely not. We'll always have to bring this patient, put a needle in the upper retroperitoneal and inject contrast. And you can see on the right, there's a opacification of the thoracic duct when we inject the thoracic duct under pressure and lack of communication of the thoracic duct with vein. That's the reason it's under pressure. And recently we started to treat this patient with lymphovenous anastomosis. You can see it here in neonate. And this is after lymphovenous anastomosis, and patient almost immediately cured. This is another example. On the right, you can see that there is lack of propagation of the contrast inside thoracic duct. It kind of stops at the lower mediastinum. However, on T2, we can clearly see dilated lymphatic duct. And when we catheterize thoracic duct and inject contrast, you can see that there's an opacification of the contrast of the thoracic duct with contrast, but there is a clot that obstructs the flow. And by moving the clot away, we decompress thoracic duct and cause a resolution of the symptoms in this patient. This is after we injected, clean up the thoracic duct. We often do MRI for scrotal-vulvar edema or lymphoria. In most of the cases, we can see a reflux of the contrast inside the perineum. This is a child with vaginal lymphoria. And again, you can see both an MRI and intranodal injection reflux of the contrast inside the vulvar area. However, this is a patient Znunan, again presented with scrotal lymphoria. And when we inject contrast, we see definitely significant dilation of the retroperitoneal lymphatics, mesenteric lymphangiectasia, but no reflux until we ask the patient walk and then scan again. And you can see here that the contrast reflux into the scrotum. This is a very important technique. We do it for everybody. So just to remember that MR lymphangiography has some pitfalls. So we also rely heavily on delayed MRI images. Why? Because they provide us additional information. Here you can see a leakage of the contrast from the tip of the thoracic duct. And you would say embolization of the thoracic duct can cure this problem. However, no, there's a parallel retroperitoneal duct. And of course, we need to embolize both thoracic duct and these retroperitoneal masses or pathways to achieve good outcome. Again, on the imaging dynamic, we only see on this patient thoracic duct. On only a delay, you can see this communication between retroperitoneum and mediastinum. This is an example of patient with neonatal chylosyncytitis, leakage of the contrast from into the peritoneum. This is a new technique described by Klaus Piper from Bonn, where they inject contrast instead of in the subcutaneous, intranodal, they inject subcutaneous, and they actually can opacify central lymphatic system. Very nice study. We don't do that just because we saw comfortable doing intranodal lymphangiography, but I'm sure some people will use this technique, but because it's technically simpler. Recently, we also got this CT scanner inside an IR, and we immediately started experimenting with CT lymphangiography. And this is, we perform it pretty much the same way as MRI. And here you can see beautiful images, what we can achieve. This is, of course, this beautiful 3D images just to impress people, not for clinical use, for publication and presentation, but really you can do very, very, very nice imaging of the lymphatic system using this technique. And of course, it's much easier and simpler comparing to the MRI. This is another example. We have very, very good correlation with injection of the contrast inside the thoracic duct. In conclusion, MR lymphangiography and CT lymphangiography are invaluable diagnostic tools for understanding of lymphatic flow disorders. There has to be always a first line in the relation of the patient with lymphatic disorders. And by all means, we need to develop better imaging modalities for other lymphatic systems, such as the kidney, liver, lung, and so on. And thank you very much for your attention.
Dr. Itkin, excellent talk. So good to see you. Thank you for a terrific talk. MRL is really an emerging area that we're very interested here at Beth Israel Deaconess. What percentage of conventional lymphangiography have you converted over to MRL? Are you doing conventional lymphangiography with any frequency now?
Of course, yes. From diagnostic perspective, they are complementary, right? For example, lymphangiography, MR lymphangiography has very good penetration, but unfortunately, sometimes the contrast does not go to the areas where the contrast or lymphatic system under pressure, for example, obstructed thoracic duct. And most of our MRLs, they converted to procedure. They're done before procedure. And of course, as a part of the procedure, first we do a conventional intranodal lymphangiography.
Sure, certainly. And then have you been doing these in primary lymphedema patients at all? And because we've done some conventional lymphangiography and we had trouble accessing the nodes because there's been an absence of nodes. I was wondering if you've ever run into those situations.
That's extraordinarily rare, the fact that we don't see the lymph nodes. I remember two patients, both of them lung transplant and calothorax, and we eventually end up doing pedal lymphangiography, and we see no lymph nodes, even on pedal, so they're completely disappearing. Right, so no, most of the primary lymphedema, the only situation right now what we encounter is obstruction of the thoracic duct, causing edema, but usually it's not just a lower extremity edema, it's the lower abdominal edema, and usually for some reason it's associated with some type of surgery. It could be spinal surgery, hip replacement, and so on. And we found that the debris occlude thoracic duct. The moment we open, the people get better. But we're not dealing with primary lymphedema at this moment. We started to work with lymphedema physician. Until now, our primary focus was central lymphatic system, but we, of course, it's come with territory, right? We couldn't avoid that. So we started to see more and more lymphedema patients and do some studies. And for primary lymphedema, maybe 5 or 6 cases. And what we found is total obstruction at the level of the groins.
Hey, Max, it's Drew. How are you? Great talk. I think you're in the middle of a busy day. Are there any patients where you would say MRL is contraindicated, or you would prefer to go with conventional, like conventional lymphangiogram?
Plastic bronchitis patients, they are morbidly obese, all of them. Besides, of course, cardiac plastic bronchitis, you just couldn't fit them inside the MRI. This is the only situation we truly don't do MRI. Or people could not lie flat, or severe anxiety, and we couldn't get them into MRI because anesthesia is not available. But no, we always start with MR lymphangiography. I'm just thinking about the situation, but I don't remember any situation where we would be worried about, like there's contraindication besides the, and we have good pacemaker program. I'm sure Boston also has a good pacemaker program, so we always can squeeze somebody with pacemaker.
For the dynamic series that you presented, those images were spectacular. What is the typical temporal resolution for those? Like what frame?
It's
each frame
approximately
about a couple seconds.
30 seconds, 20, 30 seconds. So what with frame you see, it's 10 minutes. So, and again, our huge hopes is that we can calculate the flow in the thoracic duct. And we published one paper, but it was very rude, this like concept. And right now we're doing animals and trying to correlate. And actually, we got a grant from RSNA to do CT lymphangiography flow measurements. It was University of Irvine. And as we speak right now, they actually started an experiment, a fourth animal. And it looks like they can calculate based on CT the flow in the thoracic duct. And this is the people that usually do coronary artery flow calculation on CT. So I trust that Sabi Malloy, he is heading these efforts. But so hopefully we'll have some calculation with flow based on CT because it's obviously much easier to accomplish.
Yeah, that's great. Thank you. Do you worry about respiratory sort of motion at all when you're doing these dynamic series or?
The thoracic duct is located very posterior on the spine. So it's not very mobile.
Okay, great.
So,
and you're injecting using, I saw some balloon insufflators there and such. Is that what you're using for conventional lymphangiography? And how are you administering the contrast for MR?
For MRI, no, we connected to the injector. We connected to the, I showed, I mean, it was quick. I showed that system that we developed to connect to injector. And the reason we want injector, of course, it's much more stable injection, but also you can more reliably calculate the flow because you know what's in flow, how much you actually injecting. Contrast. So maybe contrast affect your flow in thoracic duct, right? So that's the main reason why we did injector, but then we liked it because it's super easy. I don't have to stand and inject by hand.
And you always do contrast ultrasound to confirm your position within the lymph
Yeah,
nodes?
you absolutely have to do it. Or fluoroscopy, because literally 30% of the time, first placement, you inject and you, I'm actually not in. So because of course, the ultrasound probe has volume averaging, right? So sometimes you think they are perfectly in, but you're not. That's,
Definitely been there.
That's absolutely, sorry for, sorry. Sorry for that. So they're over. So so absolutely, it's necessary to do that. Otherwise you will have 30-40% negative studies. And it's not necessarily contrast you have to inject. So my partners in Netherlands, they actually inject saline and use power. You first you swell, but also they can use, use some type of power Doppler to see the movement. I don't think they published about that, but they showed that. But I mean, the contrast cost probably $20. The program cost $30,000. So fortunately, all our machines come with the program, and we can do that. But the poor man power Dopplers obviously will work as well.
But if you're not in, it doesn't obscure it for reaccessing the node, or does it?
No worries. Sorry, can you repeat that? Sorry for that.
Well, I was just wondering if you were not in, does that obscure the node, having the contrast ultrasound?
A little bit obscure the node, right? But you can go back and reposition needle. It will be perfectly in. There's no problem at all.
Any other?
Interesting. Yeah.
Fascinating. Great talk.
Thank you very much.
Thank you
Thanks so much.
Good to see you.
Take care.